Thank you for that introduction. It's a great pleasure to be here. I have to say, this is very daunting because I was told that this is a public lecture and therefore there could be anybody from school children through to people in their 90s, plus of course the Physiological Society. And so it's very difficult to know where to pitch this talk, so I apologize if you feel it's been pitched a little low in the brain for you, somewhere around the brainstem. But I'll be talking a lot about concepts and ways the disease evolves and what we're trying to do to measure it and follow it, rather than going into a lot of the data behind it. So I called this talk Seeing is Believing because, of course, we're all highly skeptical, and if one winds back the clock to 330 BC, when Aristotle, having worked out from first principles by the movement of the stars that the world, the globe, had to be a globe. The world had to be spherical. It was not flat after all. Even if you were to go and look now, this is the Namib Desert, from a balloon, you would still say it was flat. On the other hand, if you were to go up in an Apollo rocket, you know it is not flat. You know it's a sphere, and we know it's a sphere because we can see it. And we have the evidence. Now, we knew it long before we could see it, but biology is rather similar. There are those people who conceptualize the molecular and cellular processes that are going on, and there are others, and I'm a clinician, so we're rather simple in our view of these things. Unless we see it, we don't believe it. So we have to be able to see it to be able to know how to deal with it. And that's really the concept I'm going to explore in my talk this evening. And the other concept is that the days of doing things on your own as a biologist are completely gone. Certainly as a medical scientist, they're completely gone. And what I'm going to illustrate to you is that we are fundamentally dependent on physicists and chemists if we're going to be able to use imaging as a tool to identify patients with disease, and in particular to follow the disease progress in a way that we can intervene on it in some intelligent way. So again, I apologize, so this is really for the lay members of the audience. We talk about cardiovascular disease as taking three forms. That's coronary heart disease, the disease that affects the coronary arteries of the heart, cerebral artery disease, the disease which causes strokes, and peripheral vascular disease or artery disease, which can affect the limbs and also the carotid arteries. But the fundamental process is the same, and it's common to all vessels. And I think one of the things that we've realized as physicians, and now moving more towards public health doctors, is that this is a disease that is systemic, it's distributed throughout the body, and to be tackling it from a single organ perspective doesn't make a lot of sense, because wherever you see atherosclerosis, it's having an impact, and if you see it somewhere in the body, you can be pretty certain it's somewhere else in the body that you haven't looked. So why is it so important? This is taken from the Heart Foundation's 2005 edition. There's a new edition just coming out shortly. UK deaths, total deaths for men, same proportions would be true for women. And when you add the three components of cardiovascular disease together, they're responsible for 37% of all deaths, making it the single biggest cause of death, even if you include all forms of cancer. This is a particularly important point for women, of course, because women are, from middle age onwards, are terribly worried about cancer, breast cancer in particular. Actually, as women, you're much more likely to die or succumb to cardiovascular disease than ever you are to breast cancer. It is much more of an issue for middle-aged and elderly women than cancer is. And then if you add the other forms of death together, you get 34%. So it is the major killer still in the UK, despite what you might read in the papers about the government having cracked it and having sorted out cardiovascular disease and coronary disease. So I'm going to start by talking about myocardial infarction, heart attack, and this is part of a campaign that we've been running recently to try to alert people to the fact that it's not a Hollywood phenomenon. People don't clutch their chest and drop to the ground, or at least not very commonly. They'll sit there rubbing their chest for ages, looking a bit ashen, a bit grey, and then they describe to us it's a bit like having a belt tightening around the chest, hence that imagery, which we hoped would prompt people to call 999. And the reason we wanted them to call 999 is about a third of them will die before they get to hospital. And the reason they die is that the ischemic event, which I'll describe in a minute, which is causing that heart attack, destabilizes the myocardium and causes arrhythmias to occur, which can be terminated if you have a paramedic by you with a defibrillator. But of course, if you're sitting on your own at home waiting for the, quotes, indigestion to go off, there's a risk you'll die, and you'll die of what is a reversible process if you don't call 999 for help. So the simple view of coronary artery disease, here's the left anterior descending coronary artery here, the right coronary artery, there's circumflex artery here. This is what a normal artery looks like. All of these micrographs are care of my former colleague Michael Davies, whose slides you'll see all around the world, rarely acknowledged to him, but they're certainly his, showing a normal coronary artery with a beautiful clean endothelium here and a nice open lumen. We know that, of course, with atherosclerosis, if it occurs somewhere down here, then the lumen becomes narrowed. That's the part where the blood flows, and there's a bit called the fibrous cap, which separates this lumen from the atherosclerosis, this lump of lipid and cellular debris, called atherosclerosis because it resembles a lump of porridge, and surgeons will tell you it is very porridge-like if they actually open up an atherosclerotic plaque. And if it's in a position down here and it's just narrowing the vessel, then a bit of heart beyond that is at risk of becoming ischemic, not getting enough blood flow when it needs it. In terms of heart attack, though, should it happen a bit higher up, and if this plaque were to rupture, and we'll talk about the processes that cause that rupture, then a thrombus will form, blood clot will form. This one actually filled the blood vessel that's been washed away to a certain extent, and this was the fatal event which caused the death of that patient, because it caused this myocardium here to become ischemic, and this patient probably died not because of the damage that occurred, because that was reversible, but because of the fatal arrhythmia that ensued straight away or fairly quickly after the onset of the symptoms. So I'm going to talk first about the biology and a rather simplistic view of a coronary artery, or it could be a leg artery, or it could be a brain artery. It doesn't much matter. They're all very much the same. And I just want to emphasize the importance of these cells here, the endothelial cells. If you're going to take care of any bit of your body at all, take care of your endothelium, because it is, certainly in terms of surface area, by far the biggest organ in your body, and it is instrumental in protecting your blood vessels from developing atherosclerosis. And it maintains not only the diameter of the blood vessel, but also the integrity and the smoothness of the blood vessel, so that blood flows evenly throughout that vessel and doesn't start to clog up and doesn't start to cause the start of a process called atherosclerosis. And we now know that one of the triggering features for atherosclerosis is what's called endothelial dysfunction. This is a rather ill-defined form. It can be defined in a number of terms. Histologically, it can be demonstrated. Physiologically, it can be demonstrated with physiological responses to hyperemic flow. And it can be demonstrated radiographically to an extent. The important thing is that endothelial dysfunction is a consequence of a number of risk factors, but it predisposes one, and there's a bit of a chicken and egg issue here as to whether high lipoproteins in the circulation cause endothelial dysfunction, or endothelial dysfunction facilitates the accumulation of these lipoprotein particles, LDH cholesterol, into the subendothelial space, which is the very beginnings of atherosclerosis and the beginnings of a fatty streak. I was going to say everybody in this room has got fatty streaks, and I say that with confidence. I was expecting there might be some teenagers here as well who would also potentially have fatty streaks, and it doesn't project very well, but this is an aorta laid open in a young person where you can just make out a fatty streak there and maybe one or two others thereabouts. We all have these things. The important thing is that we do not wish them to progress onto a complicated atherosclerotic plaque. So what are the causes of endothelial dysfunction and the accumulation of this lipid? Well, they happen to be the same risk factors that we've learned from epidemiological studies predispose people to cardiovascular disease. Smoking in particular causes endothelial dysfunction, again, physiologically measurable. This is from a campaign the Heart Foundation ran a year or so ago, trying to show kids how much oil they actually consumed if they had a pack of crisps a day. And this girl has it all dripping down her front. It's disgusting. This is meant to imply that too little of this, the antioxidant 5-a-day vegetables, and too much of that is going to lead to endothelial dysfunction, salt, hypertension, and in particular these days, obesity and type 2 diabetes, and the inflammatory process that is part of that syndrome clearly leads to endothelial dysfunction as well. So there's a tie-in there between the epidemiology and what we're beginning to understand about the cell biology. So if this is allowed to progress, then you get a small accumulation of lipid here, and that combined with endothelial dysfunction leads to an inflammatory response and the expression initially of selectins and then adhesion molecules, which cause rolling initially and then capture of leukocytes, particularly macrophages, but also T cells as well, lymphocytes as well. Here's a micrograph from Mike Davies' work again, showing this beautiful endothelial surface here like a pavement, but leukocytes that have stuck to it. And by way of demonstration from Dorian Hasgard's lab here, this is not a coronary artery, but this is an inflamed artery showing you these leukocytes, which ought to be shooting through here at a heck of a pace, but aren't. They are rolling because of the selectins expressed on this endothelial surface. And if we then allow that to progress, we end up with a process whereby they've not just rolled, but they're actually clogging up the vessel and beginning to accumulate. So if the endothelium is activated in this way, you get leukocyte accumulation. Going back to a cartoon representation of that, so here are the leukocytes that have now been tethered by the adhesion molecules, and they then migrate in to take up the lipid, which is dealt with as a foreign substance would be by any macrophage. In other words, if you have bacterial inflammation, macrophages will get in there, they'll ingest the bacteria and do something about it to neutralize the toxic effects of the bacteria. In this case, they become these macrophage foam cells, which go on sometimes to die, but have other consequences, and contribute to the growing lipid core, which is the atherosclerotic plaque. But their influence isn't wholly bad, because they also send out a whole slew of chemokines, including the platelet-derived growth factors, TGF-beta, and a variety of others, which stimulate the underlying smooth muscle cells, which are in a contractile phenotype. They normally are present just there to contract and relax to regulate blood flow. But given the appropriate stimulus, and certainly if they move out of their normal environment back here in what's called the media of the vessel, then they will migrate into the intima, where they become a repair cell, basically creating a new vessel wall over the top of this inflammatory focus. And the best analogy I can give you for this is of a boil or a spot on the skin, whereby you get an inflammatory focus, but as the inflammatory process begins to die down, then you're often left with a fibrotic nodule where it's not smooth muscle cells, but it's fibroblasts that's created this walled off lump that you feel in the skin. So if that's all that happens, you end up with what I would call stable or safe atherosclerosis. A lipid core, but a nice, thick, robust fibrous cap. And here's an image from Mike Davies again, showing you definitely a narrowed lumen and a big atherosclerotic plaque, but a very, very thick, healthy-looking fibrous cap. This is not going to kill anybody. Clearly, this person died, otherwise we wouldn't have got their coronary artery, but I presume they died because of a different lesion. And so this is a narrowed coronary artery, but it's not a potentially fatal coronary artery. But what happens if the disease progresses? Well, we know that as these inflammatory cells become more activated and as they interact with the T cells, then they start to become cytotoxic to the smooth muscle cells, which are the only cells capable of regenerating this fibrous cap, and you get a process of apoptosis or necrosis of the smooth muscle cells. And as a consequence of that, and I now wish I brought some other slides to show you this process here, these apoptotic cells elaborate matrix vesicles, which are almost identical to the matrix vesicles produced by early bone cells, and they go through a process of ossification, and you get calcium laid down in the intima of this blood vessel. And so here's a lesion here, there's a lumen, thick atherosclerosis all around it, but in this area here there is a thick area of calcification, which can actually ossify if it's allowed to progress far enough. But I want to come back to the calcium because it's quite an important marker for the presence of the disease. And if the progress continues, then these inflammatory cells, they elaborate a lot of matrix metalloproteinases, which digest away the fibrous cap. They've killed off the only cells that can repair it, so the balance is tipped wholly towards tissue destruction, and they rupture through. And the point I haven't made is that this lipid core is highly thrombogenic. Once a platelet gets a sniff of the lipid core, tissue factors activated, and you get platelet aggregation, and they start to accumulate, and the beginnings of thrombosis. And if that progresses further, you get the image that I showed you earlier on of the ruptured plaque with the thrombus sitting here extending into the lumen. Importantly, it doesn't always completely occlude the lumen. We now know that this is occurring actually all the time in patients with atherosclerosis. They're developing these micro ruptures, because if you look at this lesion here, this would have been a tiny lesion before it ruptured. That would have been a non-symptomatic lesion. It wouldn't have been causing angina or any flow disturbance in the coronary artery. If it ruptures, and if that were to resolve, then what tends to happen is a new fibrous cap forms over the top of it. The patient doesn't know any of this is going on. The person, I would say, they're not a patient at this stage. So you or I do not know this has gone on. And the new fibrous cap forms over the top. But this process of healing over the top advances the lesion very rapidly, such that the lumen becomes narrowed, and then the disease declares itself as angina or a symptom of reversible ischemia. So atherosclerosis doesn't necessarily evolve very, very slowly and gently, as I'm afraid a cartoon I'm going to show you in a minute depicts. It can evolve by fits and starts of rupture and repair, rupture and repair, rupture and repair. So rupture is an event which is both fatal but also instrumental in the progression of the disease. And I just wanted to show you this, this histology here, because this is a lesion which has ruptured, killed the patient. But if you get rid of that thrombus and you were to paste the fibrous cap back, you've really got a very widely patent blood vessel. So this was a tiny atherosclerotic lesion. This was not a big lesion, yet it ruptured. And although not the same lesion, if you looked at the histology of that fibrous cap at the point at which it ruptured, the dark brown staining CD68 for macrophages, this is all inflammatory cells. Only back here do you get an area where you've got smooth muscle cells and no inflammatory cells. So the inflammatory cells here have killed off the smooth muscle cells, they dominate, and they've ruptured through to cause the fatal thrombus in this person. So inflammation is all important in atherosclerosis. So I'm now going to, I hope, show you the first part of an animation sent to me by a friend and colleague of mine, Peter Libby, in Harvard, which just animates that process for you, meant mostly for the school children who haven't appeared, but never mind, we'll go through it. So we're looking here at the coronary arteries and the way atherosclerosis develops. In one of them, here's that left anterior descending artery shown here. This is the vessel in cross-section, and this is the blood flow, obviously. Endothelial surface here, subintima here. Along the lines of the cartoons I've already shown you, the lipoprotein particles will start to appear. They migrate through into the subendothelial surface here, activate the endothelium, and you get the rolling and the tethering of the inflammatory cells through the adhesion molecules. Diapedesis into the subendothelial space, and accumulation of inflammatory cells. They take up the lipid, become foam cells, and the core grows. But importantly, so do the smooth muscle cells migrate there to form this protective fibrous cap. Safe atherosclerosis. And as that progresses, one of the important things to note, and I'm going to come back to this, is that the lesion grows, but it grows outwards, not necessarily at the expense of the process of remodeling. Here's the inflammatory cell activation, the T cells and the macrophages, both by cell-cell contact and by elaboration of cytokines, activating, metalloproteinases coming out, digestion of the fibrous cap, platelet activation, thrombus formation, myocardial infarction, heart attack. So that's what we think is going on in terms of the development of atherosclerosis. And the point I'm really trying to make is the thing that's all important is inflammation that's driving the process. And what we're trying to do in terms of our treatments is to reduce that inflammation and get rid of it. But we need to know whether we're achieving that or not, and we'll come back to that. So we go from a normal artery to a fatty streak, which produces no symptoms at all, to, if you're lucky, stable atherosclerosis, which will limit flow and give rise to symptoms of angina. This is chest discomfort when you push yourself, or when you try to do a bit of physical exertion, or when you get emotionally charged or anxious. And what you hope to avoid is this process of rupture and thrombus formation here. I don't want to talk a lot about treatment of angina, but I've got one slide that just shows you how we manage this process and why it is a relatively benign process these days. and that is we do an angiogram, and I'll talk more of that in a minute, to show where a stenosis is. It's a very simple procedure these days, done under a local anesthetic, to introduce a catheter from the groin, which is fed across the lesion here. A balloon is blown up. It's not subtle. This is rather crude. It's just squashing the atheroma back into the blood vessel wall. And if you just took the balloon out, what would happen is the blood vessel wall will just recoil back to where it was, and you're liable to get what we call restenosis. So we've progressed onwards now, so that on the outside of that balloon is fitted a crimped stent, a metal structure here, which as you blow the balloon up, expands with it, and then when you deflate the balloon, the stent stays put. So what in effect is left behind is a metal scaffold, so that the recoil cannot occur, and that part of the vessel remains patent. And I suspect there are people in this room who've had this done. And the only issue then is you want to keep this patent because it's metal, so that means that you have to have fairly aggressive antiplatelet treatment until it's re-endothelialized. The only risk then is that it might cause a rather vigorous repair response and cause what we call restenosis. We try to deal with that by having drugs eluted from the stent that inhibit that vascular proliferative response that I showed you earlier on, the repair response, and those are the drug-eluting stents. But as I said, I didn't want to dwell on that too much. Now, I've talked about heart attack. What about stroke? Well, stroke is the same process. It's due to atherosclerosis, but usually here in the carotid artery, and usually due to a fairly tight lesion sitting here in the either the internal or the common carotid artery, and is commonly due to embolization of platelets and debris coming off the atherosclerotic plaque and heading north up into the cerebral circulation, so that here's the embolus coming up the middle cerebral artery. It goes as far as it can go until it stops because the vessel's too narrow to go any further. That puts this part of the brain at risk of ischemia, and unless that clot decides to move on, you're left with an area potentially of brain death. And this is a PET scan of a patient who's had an embolus showing lactate levels extremely high in this area here, probably irreversibly dead, that area there, but showing there's a big area that could be salvaged potentially there, provided the blood flow can be restored as quickly as possible. So, onto the physics, because we understand the biology now. What we need to do is translate the biology to the patient. And what we need to know as clinicians now, so I'm wearing my clinician's hat, not my cell biologist hat, is what I want to know when I see a patient is, has that patient got a plaque? And if they have, is it stable or is it unstable or unsafe? Now, our gold standard for imaging the heart is coronary angiography. So a catheter is induced into the femoral artery. Here, you can't see it very well on this image, I'm afraid, but there is a blue catheter sitting here in the descending aorta going up there over the arch. There it is, and a blow-up of it here, and it then lodges in the ostia of the right and the left coronary arteries, and we can then deliver dye, contrast agents down there, and look at the coronary arteries. So on the left of the picture, here's a coronary angiogram. Could do with the lights down a bit maybe at the front, it might help. I'll just run that one again. Thank you. So here's the left anterior descending, the circumflex artery. Not too bad, the circulation in that one. I'm just going to run it again and stop it at a particular point. Okay, so we'll stop that one there. We'll now move on to this one. Similar, not the same patient, similar, but there's a very obvious difference. And again, I'll just run it and stop it. If you compare that with that, this person's circumflex artery goes where it should go. This one grinds to a shuddering halt. There's a thrombus or a plaque which has completely blocked this artery. I would suspect this patient's had a lateral infarct. This area of heart has had a myocardial infarct as a consequence of a ruptured plaque and thrombosis at that point there in their coronary artery. So the angiogram tells us something. The problem is it's invasive. We've got to stick tubes in people, tubes up to the heart, so it carries a small risk. We have to inject dye, which some people are allergic to, and it involves radiation. We can cope with all of that. We've been doing angiograms for 30 to 40 years. The biggest problem's been demonstrated since we've had this gadget, and this is the intravascular ultrasound. So there's an ultrasound probe on the end of this catheter. There's the cardiologist's thumb, just to give you a sense of scale here, and this is the catheter just looped in his fingers. And this is the image you get if you put the ultrasound probe down the coronary artery in the same way as we've just put a catheter, but this time you thread the ultrasound probe right the way down the artery. And you get an image of the lumen of the artery, but also you get an image of the thickness of the vessel wall. The normal vessel wall here, the intimal boundary, is this dark ring here. Everything inside it, this concentric ring here that's highlighted in green, is atherosclerosis. And so when you take a patient who is being investigated for coronary artery disease, and it doesn't matter where you look, at point A, B, C, or D, the angiogram looks pretty okay. I mean, cardiologist colleagues of mine will say, well, actually, there's some minor narrowings here. It's not perfect. I would agree with that. On the other hand, you would not say there's anything really worrying about that person's coronary artery. But if you look with the ultrasound probe, point A, thick concentric atherosclerosis, calcium here is throwing an acoustic shadow there. So this is quite advanced atherosclerosis. At point B, same again, concentric thick atherosclerosis, calcium. C, same again, big slab of calcium here, so the sound waves don't get through and you get this acoustic shadow, and likewise over here D. In other words, this vessel is diseased from top to bottom, yet it looks normal on the angiogram. And that's because of this process I've already alluded to a few minutes ago of remodeling, which Glagov first described, whereby the vessel expands to accommodate the atherosclerotic lesion to the expense of the outward movement to maintain a normal lumen, provided the development is slow enough. But ultimately, as it progresses, you then get narrowing of the coronary artery. So if you're fortunate to have slow progression of your atherosclerosis, then this is probably what will happen. Your vessel will dilate, it will accommodate it, you won't know it's there, but it will ultimately start to cause symptoms, probably angina or other. This does not, of course, allow for the process that I've just described of the rupture repair process, which takes place not over months and years, but over days. And so the vessel does not have a time to accommodate that. And that's why somebody can go from being 100% normal running a marathon one day, pitching up in my clinic the next week, getting angina when they walk 100 yards. They had a plaque rupture during the marathon. They didn't know it. They've repaired their plaque, but the repair process is now taking place at the expense of lumen, and the vessel is no longer delivering the oxygen the myocardium requires at exercise. So the important point is this is all remodeled coronary artery. So the angiogram doesn't tell us anything about that. The other problem is when we do see a narrowing on the angiogram, this is actually a cerebral vessel but sideways on, I want to know, is it a safe one that I don't need to worry about, or is it one that's just about to rupture and cause either a heart attack or stroke, depending on where it is? And I can't tell from the angiogram because the angiogram is just a silhouette. It tells me nothing about the vessel wall. So it's a very blunt tool to try to get a handle on the biology of atherosclerosis in a patient, because it doesn't identify all the lesions and it can't discriminate safe from unsafe atheroma. So what other imaging tools do we have available to us? Well, we have the CT scanner, and CT technology has moved on extremely fast. It does have the disadvantage, as does angiography, that it requires radiation, and it uses quite a lot of radiation at times, but it does give quite exquisite pictures of the vasculature. So this is, again, we might do better if we could have the lights down a bit. This is an angiogram, but a CT angiogram, so no tubes have been put into this patient. We can see the aortic arch, you can see the carotid arteries, the arm vessels, the pulmonary vessels, and over here you can actually see the coronary circulation. So this is a non-invasive test, and furthermore, on this test, we're able to get perfusion data which says this area is underperfused here because of, and it's rather subtle, a narrowing here. The problem is, although this can be achieved non-invasively, it still doesn't actually give us any more information about the state of that vessel than a standard angiogram does. Nevertheless, it is an advance because it's non-invasive, and what it can do, and it's very good at doing, is picking up calcium. And we can quantify that calcium and give it a number. And there's enough data out there now to show that if you just put somebody into a CT scanner and do a quick scan of their chest, and it takes minutes to do that now, it does take a lot of radiation, mind you, if there's no calcium there, that person probably doesn't have any coronary artery disease. If there's a lot of calcium there, they probably have quite extensive coronary artery disease, and it's scored. So if you've got 400, 500 units, you've probably got extensive coronary disease. If you've got no units, you've got none. The difficulty is the people in the middle. Beware of this. Bupa's offering it left, right, and center to people at the moment to tell you whether you've got a healthy heart or otherwise. If you get a no calcium score, brilliant. The trouble is most of you won't. You'll get something that's in this territory here, some calcium. We don't know quite what to do next. Bupa will suggest you go on and have all the other cardiac investigations and treatment, which is not necessarily evidence-based. We need to learn more about what this test is telling us, but it is something that's catching on in a big way, and it shows the power now of non-invasive imaging to pick up a biological effect in the vessel which we didn't understand until relatively recently, but which is helping us. So it can identify calcium, and it has good anatomical resolution, as I showed you, even down to relatively small coronary arteries. But it has radiation. So the other imaging modality which has really come to the fore in clinical practice is magnetic resonance imaging, the patient having to lie inside this magnetic coil. The beauty of this, of course, is no radiation whatsoever. In fact, we don't know of any downside to magnetic resonance other than this. And that is, if you enter the room with anything metal anywhere about you, these things are turned into lethal missiles. And so a set of keys will shoot across the room at 80 miles an hour and can do very, very serious damage to somebody or something. So the operators must leave all the metal that they have on their bodies outside the room, as does the patient, which means you can't do it on patients who've got prosthetic hips, who've got pacemakers, for instance, for the same reasons. It also wipes your credit cards, which is not a good thing to have done. So what does MRI do? Well, it does give you exquisitely good data on the anatomy of blood vessels in relatively large vessels. So here's that carotid artery here. So we're taking a slice using the magnetic resonance scanner. Again, probably if the lights could go down a bit, it would be helpful. And this is looking at the left carotid artery. And you can see there is a big atherosclerotic plaque there. It doesn't matter what the angiogram tells us, we can see the plaque. So we see what's in the vessel wall. And if you play around with the settings of your magnetic resonance scanner, you can, with the eye of faith in these big vessels, pick out different parts of the lesion which correspond to fibrous cap and to lipid core. So the anatomy is very good. The problem is MR scanners can't really do this very well yet at the level of the coronary arteries. We're really pushing at the limits of the technology, but I think clearly we will get there one day. So what's MR able to do is, well, it can identify all the lesions in large vessels. The problem is, I still want to know, when I see a lesion, is it inflamed or is it not? Because that's the thing that's going to determine whether this person is at risk of a fatal coronary event or stroke. So that's where the chemists now come in. Inflammation is a metabolically active process and therefore requires a substrate, the substrate usually being glucose. And you know that we can ask chemists to radio-label glucose molecules, in this case deoxyglucose, so that we can trace its pathway. And we asked the question in this is now to our lab's work in Cambridge a few years ago, could we use FDG uptake, glucose uptake, as a marker of inflammation inside an atherosclerotic plaque? So the first experiment we did was we took an atherosclerotic plaque shown here in cartoon form, but this was a real live plaque taken out of a patient's neck. I forgot to say that if a patient comes having had a mini stroke, this is a stroke which has got better within 24 hours, completely resolved, you do an angiogram or indeed an MR image, and you show a narrowing in that coronary artery. The evidence suggests that that patient would be better off if a surgeon were to open up that carotid artery and core out that plaque and sew up the artery again. The trouble is, to save one stroke, lots of patients will have to undergo that surgery needlessly and at the risk of having a stroke during the operation. But we do get the tissue. So it has its benefits, if not to that patient. So having got the tissue, we incubated it this time with tritiated deoxyglucose in the laboratory, in a dish, and then we put a photographic emulsion on it, laid it down for several weeks to do an autoradiogram. And here is the autoradiogram showing the black puntate markings here, which are the silver grains, overlying the area of the plaque that has the most inflammatory cells. There aren't any in the core, there aren't any in the fibrous cap, but there are silver grains all the way along here, and these silver grains are all in macrophages. So this was proof of principle, if you like, that the inflammatory cells in a plaque, albeit in vitro, in a test tube, took up enough glucose for us to be able to detect it if we used an autoradiographic technique, which is a long way from saying this would work in a human being. So the way to try and do this in human beings is using a PET scanner. There are different forms of a PET scanner again. Some are a tube like the CTs and MRI scanners. They're becoming more and more sophisticated. So what are we doing with a PET scanner? Well, in a PET scanner, what we want is a positron emitter. And in this case, it's fluorine 18. So the chemists tag deoxyglucose with fluorine 18 for us. Fluorine 18 gives off positrons, which meet electrons. They annihilate. And you get gamma rays given off orthogonally. And so you have an array of detectors around the patient that are picking up these incident gamma rays, and they're able then to pinpoint to a certain extent where the source of the gamma rays is within the individual inside the scanner. So we inject fluorodeoxyglucose into the patient's circulation. So this represents circulation blood here. Here's the endothelial barrier. This is a notional inflammatory cell. The FDG enters through normal glucose transport pathway into the cell, where it enters the glycolytic cycle, and because its deoxyglucose gets stuck, it doesn't progress any further. It remains there, giving off its positrons, and it accumulates according to the metabolic requirements of that cell. The more metabolically active it is, the more it will accumulate. So, can we use this to detect inflammation or metabolic activity in humans? This is what PET is traditionally used for in clinical practice. It's to look at metabolic activity in the brain, to identify areas of the brain which are most active, but also, probably its most dominant role these days is looking for metabolic activity in malignant cells in patients. So here's some of the deoxyglucose in the bladder of this patient, but it's also been taken up by a number of tumors in this person, and that's what it's predominantly used for. But we tried to use it for a different purpose. We took a patient who'd had a recent mini stroke. We did the angiogram, and it showed, here's the common carotid artery, there's the internal carotid artery, there is the lesion which we think embolized to cause this mini stroke, and the question was, could we see it after we'd given that patient fluorodeoxyglucose in a PET scanner? And the answer was, yes, we could, and there is the hotspot. The trouble is, you have to take it on trust that I'm showing you the hotspot that sits there and not some of these other hotspots, because this is the tongue. The patient, you cannot stop patients talking while you do this, and so the tongue takes up FDG, the brain's up here. So the problem is, how can we marry the anatomical picture we have saying where a lesion is with the metabolic picture we're getting from the PET scan? Because although we can identify inflamed plaques, we've shown that in vitro, and if you trust me, in vivo, we have very poor, virtually no anatomical resolution from the PET scanner. So what's the solution? Well, a hypothetical solution would be if we could combine MRI, the anatomy that we get with MRI, with the exquisite sensitivity to pick up inflammation from a PET scanner, then we might be getting to where I want to be, which is to say, yes, you've got an atherosclerotic lesion, and I'm afraid, yes, it is inflamed, and we need to do something about that before it causes you any major problems. So here's the internal carotid lesion. That's what the MRI looks like of it. There's the lumen, there's the plaque. Is it safe? Is it unsafe? Hypothetically, we'd like a PET scanner to tell us whether it's inflamed or whether it isn't. That was a slide I used a few years ago. We've moved on from that now, and I can now show you a real image. This is a real image generated in Addenbrooke's Hospital by James Rudd and John Walker, who was PhD students with me. Here's the MRI, an MRI scan showing you an internal carotid artery atherosclerotic lesion, and here is the PET scan superimposed on it, showing you lots of PET uptake in all sorts of places. That's the spinal cord, and showing you that you really do have to co-register these things very well. But this hotspot here is sitting bang on top of that lesion there. So that's great. The problem is, what we actually have to do here is we put a patient in an MR scanner and get them to lie still while we take the picture. We then put a collar on them, and we move them across to the next scanner, and we lie them down, tell them not to move at all, and we do the PET image, and we try to co-register the two, and it's pretty cumbersome. But it does have its value, and the value we think is beginning to be shown now in some of the other studies we've done. So here's a particular case of interest. This was a patient who'd had a mini stroke. We did the PET scan, and this is now a view like this. So there's the chin here. Again, if you could put the lights down, it would help. The chin just about there, and you can see the carotid artery there, and you can see a linear bit of uptake there, apparently in the carotid artery. That's what we expected to see, an inflamed plaque in the carotid artery. Here's the PET scan of the patient with a section through the head here, and here is the co-registration with the magnetic resonance scan. Now, the carotid artery is here, and it is indeed atherosclerotic. There's a big plaque sitting there eccentrically over on this side here. But the hotspot, this hotspot, is here. And actually, this is the vertebral artery, not the carotid artery. And if we go back and we look very closely here, we can see actually, that's right. The carotid artery is this one here, which hasn't got much inflammation. The vertebral artery is that one there, which has got a lot of inflammation. And this patient actually, when we did the CT scan, had an occipital infarct. In other words, he'd had a mini stroke, but the stroke had arisen as a result of inflammation in this artery, not in the traditional one. He did have a narrowing in there, and by conventional wisdom, that was taken out by the surgeon because that's what the evidence base is. We think that was the wrong lesion. You can't get at this for surgery, but we rather suspect, although we have no evidence base for this at the moment, that maybe that was the wrong vessel targeted because we didn't have the ability to do the imaging to tell us what the cell biology was rather than just the anatomy. So when we combine PET and MRI, it's non-invasive, great, no tubes in the heart, no injection of dye. It does require the radiation for the PET, though with sophistication that radiation dose is dropping, but it can identify inflamed lesions, and you get good anatomical resolution by virtue of the MRI. So we would dearly love to be able to get away from having to put patients in two separate scanners a few minutes apart. Can we get a single scanner? The answer is we're starting to. This is a combined PET-CT scanner, and these are now becoming commonplace in most hospitals, where from a single pass of the patient through the image, you get the CT scan and the PET scan. This is a cancer patient showing you cancer here, sited. Well, you can see the lesions here, and you can see exactly where they're sited. The trouble is with that, PET is radiation, CT is radiation, so the combined dosage is pretty high. Now, in a patient who is sick and whose life depends on finding out where the cancer is and doing something about it, then we can tolerate giving them reasonably high radiation doses. On the other hand, if you're just dealing with people on a day-to-day basis who may have 20 or 30 years of life ahead of them, you don't want to give them too much radiation. So we would dearly like to have a combined MRI and PET scanner. This just shows you what can be done if you've got a very good CT scanner and a good PET scanner. These are slices taken from the heart, starting near the base and going through towards the apex. Here is this white stuff here. This is calcium that I talked to you about that you can pick up with CT running down the coronary artery. But then, when you superimpose the PET, as you start moving down through the heart, we start to see a hot spot appearing, which gets hotter and hotter and hotter and hotter. And what this is showing you, that in this clearly atherosclerotic lesion in this coronary artery, there is a hot spot of inflammation midway down it, which has been picked up by this combined PET CT scanner. And this is the sort of image that we're starting to get with the equipment that's already available now in Addenbrooke's Hospital. Where we would love to be, though, is to have a combined PET MR project, and there's a group in Cambridge now who've patented this, who are developing it, and there are a couple of appearing around the world now where the technology of being able to use PET at the same time as magnetic resonance in a single scanner is beginning to become a reality. And when it does become a reality, then I hope what we'll be able to do is to identify patients who have inflammation in their plaques and know what to do with them. Why is it so important to be able to measure the inflammation in the plaque? Well, one, we don't want to go in and take plaques out with operations unless we have to. Two, because we want to know whether treatments which are now being designed to deal with the inflammatory process of atherosclerosis are actually doing any good. You'll all be aware of statins, and for those who aren't, these are these drugs which have been around now for about 10 or 15 years that are very good at lowering cholesterol levels. And we now know from thousands of clinical trials worldwide, they protect people from heart attacks and indeed strokes. But actually, if you do the angiogram, remember the angiogram, this is just the silhouette through the middle of the vessel, they don't change the image at all. So the lesion stays there, yet there are fewer heart attacks and strokes. And the only conclusion that you can logically draw from that is that the lesion has become stabilized, and there's now good cell biological evidence to say that that's the case. In other words, statins, if you like, almost by accident, but by virtue of the fact that they push down the cholesterol levels so much that the driver for inflammation is reduced and the whole inflammatory process dies down and the repair process kicks in, so you end up with something like that, are just one of now a whole raft of drugs which the pharmaceutical industry is trying to design to tackle this inflammatory process. But what they don't want to do is have to do multi-site, multi-thousand, placebo-controlled outcome trials at the cost of billions to wait 5 years and count the number of people who've had strokes or heart attacks at the end of the day to find out whether these drugs are working in terms of plaque stability. What they would love to be able to do is to take somebody who has an inflamed plaque, give them the treatment, and then ask the question in half a dozen patients, not 500,000 or whatever, after treatment, has that lesion become less inflamed? This is hypothetical again, I hasten to add. But this is not unrealistic, and we're now at the point where we think we can use this sort of imaging as a tool to measure what is going on in terms of the biology of the disease, rather than being stuck where we were some years ago with the anatomy of the disease, because the anatomy is a very crude indicator, firstly of potential outcome, but secondly of how treatments are working. And this is still in its infancy. I think what I've told you today is proof of principle, what I think is potentially doable. Now that the world has agreed, and there are a few groups that were doing this, and there are more and more doing this now, and the manufacturers of the imaging equipment have cottoned on to this, this will move very quickly. And I think we will find within the next 5 to 10 years, we will, with a single image, be able to say whether you have atherosclerosis, and if you have, how extensive is it anatomically, but much more importantly, is it inflamed atherosclerosis, and therefore is it a threat to you? And then, has the drug that we've given you worked over the first 3 to 4 months of its dose, rather than giving you all the drug in the hope that fewer of you will be dead in 5 years than if you hadn't taken the drug, which is where we're at the moment. So I trust you understand why I use the term seeing as believing. As medics, wearing the medical hat rather than the cell biological hat, I'm very skeptical. Unless I can see it with my own eyes, I tend not to believe it's there. We're now beginning to reach a point where we can actually see what's going on, and it's all because of imaging and this interaction between physicists and chemists, and long may it carry on. Thank you.
Yes. So, I believe you'll take some questions. Does the audience have them?
Yep, I will.
Do we have anyone want to ask some questions from the audience? We have some microphones.
Or two.
In case you missed the question, because the microphone wasn't working initially, could she have a glass of red wine or two? Didn't have time to go into any of the epidemiology of this. The epidemiology suggests that alcohol, some would argue whether it's red wine only. Actually, I think the evidence suggests all forms of alcohol are in some way protective against cardiovascular events. I don't think we truly understand why that should be. The epidemiology shows fairly clearly that if you are a moderate drinker, you are less likely to have heart attack or stroke than either if you're teetotal or if you're a very heavy boozer. The best buy at the moment for hypotheses around it is to do with antioxidants and and I didn't go into the whole antioxidant story in this because I was pitching it at a somewhat different level, but that is where the best money is at the moment, that there are antioxidants in either alcohol or red wine that reduce one's risk of having either the atherosclerosis in the first place or the event that follows on, and I don't think we have a clue as to which it is. And I think we're only just understanding now that the event that occurs, the heart attack or the stroke, is the final common pathway from the development of atherosclerosis, the inflammatory process, and the plaque rupture event. And drugs and lifestyle modifications even that have an impact on that, we still don't know whether they're having an impact on the atherogenesis end, in other words, you still get the disease, but you don't get the plaque rupture, or whether they're actually stopping the plaque from developing in the first place, and we've got a way to go yet.
Well, then what about smoking? Does smoking accelerate rupture or the building of plaque?
That's a fascinating question, not a plant, I have to say. If I were answering this question a year ago, 2 years ago, I'd have said that the likelihood is, again, it's the oxidative stress which cigarette smoke causes on the endothelium, which predisposes the development of atherosclerosis. And I think that's probably true. What's been remarkable out of several communities now, it's happened in Ireland, it's happened in America, and it's, I gather, recently happened in the UK, that within 12 months of a smoking ban in public places, there's been quite a precipitous drop-off in numbers of patients reporting to A&E departments with what we call acute coronary syndromes. In other words, clinical features that are due to plaque rupture events. And none of us would have predicted that, but it is beginning to be sufficiently consistent and repetitive that one has to take notice of it and think there's a real phenomenon here. That, therefore, argues, in my view, for something to do with the tail end of this. In other words, I don't know whether the cigarette smoke is having any effect on plaque rupture. I suspect not. But what it might be having a major effect on is the platelet aggregation process that occurs as a consequence of it. And if you're in a smoky environment, your platelets are stickier. You're more likely to go on and have a clinical event than if you're in a smoke-free environment where you may just have a chance of clearing the platelets and repairing your plaque. But no evidence for that at the moment. Somebody over there.
I'm just interested to know, are there any circumstances in the body where the process of plaque formation can actually be reversed? Can the body dismantle plaques? Is that possible?
Very difficult to know, because we haven't until very recently had the tools to follow the natural history of a plaque in human beings. The best answer I can give you is that there may be potentially some small regression, but I think this is like any other inflammatory process. So if we go back to the analogy of the boil in the skin, if it ruptures, it heals, but you're always left with a scar. You're always left with a nodule or a lump somewhere where that tissue repair process has occurred. And I think what tends to happen, and what the evidence suggests, is that if you stabilize the process, if you reduce somebody's cholesterol sufficiently for it to do that, then you get some retraction of the lesion, and you get a lot of fibrosis of that lesion, but it doesn't go away. And then, of course, you get the remodeling of the vessel, so it ceases to be less of an issue anyway. But because pretty much all of our data in man come from angiographic studies, and we don't therefore know what's going on inside the vessel wall when we squirt dye down the lumen, we haven't really been in a position to try to answer that question. All I can say is from animal studies, there is relatively little evidence for anything that will cause atheroma to disappear once it's fully established. I mean, in the very early stages, the fatty streak stages, then yes, you can get that to resolve. But once you've got complex plaques with thick fibrous caps, I don't know of any intervention that will make that completely disappear. It always remains, but in a more stable and more fibrotic and less dangerous form.
Anyone else?
Since this is a process occurring in everybody with aging, should we all be taking drugs to lower cholesterol, to the poly pill? Should we all be...
Oh dear, I was hoping to avoid the poly pill. How should I answer that? I think, do we want to have statins in the drinking water? The answer, probably no. And that's because, like any other drug, albeit a drug with a phenomenally good safety record, there are some people who undoubtedly get into trouble with statins, mostly muscle problems, and they can be quite severe in those very few who get it. I mean, you have to treat 100,000 patients for a year to get one severe muscle problem. The trouble is, each one of them then tells the Daily Mail, and it's out in the headlines all the time. So there are lots of them as far as the Daily Mail is concerned. And so the difficulty with that is that I'm not, as a physician, wedded to polypharmacy as a route to getting rid of this process. Lifestyle modifications, if imposed aggressively enough and early enough, will do everything that the statin does. In other words, you can improve endothelial function, you can raise your HDL, you can lower your LDL, if you don't smoke, if you exercise, you eat the right foods. That is all relatively achievable at a public health level without resorting to drugs. In the intermediate future, I would say, we have to carry on with the process of trying to identify those people who are at highest risk. And at the moment, that's a fairly unsubtle way of counting risk factors and computing them and saying, well, you've got a greater than 1 in 20 risk over the next 10 years of having a heart attack, therefore we'll give you a statin. But that's an economic argument. I would love to see that threshold come down, because I do believe that the statins are extraordinary at reducing events, provided they're used judiciously, and that means they're used to really put the cholesterol down, not just a homeopathic dose. And that's where we're getting into difficulties over the economic arguments, whether you have just a tiny dose of a generic one or a big dose of an expensive one, because the big dose of the expensive one will probably do better for you than a small dose of the generic one. So there are lots of debates to be had around that. As these drugs become cheaper, of course, then they will become commonplace. But I guess I would say, and I should say, that by and large, atherosclerosis is a preventable disease. It's mostly due to lifestyle and what we do over the first 2 to 3 decades, clearly influenced by our genetic background, genetic makeup. And if you've got FH, clearly you're in trouble no matter what you do, and you do badly need statins to help you. But at a public health level, we ought to be tackling it in terms of lifestyle. But once you've reached a certain level of risk, then I think you should be looking to take a statin. Aspirin's a different issue. You have to be at a reasonably high risk for the benefits of the drug to outweigh the potential disbenefits in terms of bleeding and other things that can happen. Bit of a wishy-washy answer. There are no journalists, I hope, here. Yeah.
Can I ask a final question? Is it true that only part of statins' action is through cholesterol?
Well,
they have other actions?
Yeah, it depends who you wish to believe, I guess. Statins certainly lower LDL cholesterol substantially. Some of them raise HDL cholesterol, so they do all the right things. They improve endothelial function. And people will say, therefore, it's through endothelial function that they're acting. The trouble is, you can never do the test of the controlled trial of a statin that doesn't lower cholesterol. What's its effect on endothelial function? So it's always on the background of modifying LDL cholesterol. What I would say to you is, I know of no evidence that needs to invoke anything other than the lipid-lowering mechanism of statins. So if you look at the delta risk reduction of taking a statin, in other words, the risk reduction of a heart attack or a stroke versus the cholesterol achieved on that statin, then it fits perfectly with the epidemiology. And if statins were doing something in addition to and over and above, you would expect it to be better than what you would predict from epidemiology, and it really isn't. But there's no doubt the statins do quite a lot of other things that we don't yet fully understand, and they may be having anti-inflammatory effects which are synergistic with the lipid-lowering effect. It's just that I haven't yet seen any data that say to me, so there must be another mechanism other than LDL cholesterol reduction. So I'm anxious to argue against that one, because there are a lot of people out there very vociferously saying statins are poisons, you shouldn't take statins, and it's not the cholesterol lowering effect anyway, it's something else, because I just don't think that's true.
Okay. Thank you very much. Is there another question here? One more question.
Why antioxidants have generally been not very successful?
I don't know, it's a good question, isn't it? Well, I think there's a certain naivety about looking at the cell biology and saying this is an oxidative process, and assuming that therefore shoveling vitamin E in somebody's mouth by the bucket load is going to translate therefore into an antioxidant effect inside that plaque, which will be protective. So I think there are lots of links in that chain where it could break down. So I don't quite know why, and for those who aren't familiar with the literature, the evidence has been we would predict and expect that antioxidants, vitamin C, vitamin E, would protect people from having heart attacks and strokes, but by and large the clinical studies have not shown that. It's a bit of a conundrum. I don't know whether that negates the oxidant hypothesis. I suspect it doesn't. I just don't think it's been a very clever way necessarily of tackling. I did a small study with Malcolm Mitchinson here in the pathology department where we tried to measure the antioxidant levels in the plaque when you gave people bucket loads of vitamin E, and actually very little of it got there. There's plenty in the circulation, and it had effects on oxidized LDL in the circulation, but by the time you got to the plaque itself, there was very little measurable effect. So it might be that, I don't know.
Okay, is there any more? Any more for anyone? Okay, so it's left to me to thank you for this wonderful display. I think we can't underestimate how powerful this imaging is and how it has changed very, very rapidly. I remember speaking to obstetricians about 25 years ago, and they were saying, you know, that before they had the ability to image the fetus, all they could do was palpate the mother's abdomen. And this is a bit like the same miracle that's occurred over this last 10, 15 years, that you really can see, as experimental scientists, we are used to seeing isolated tissues, to using a microscope to see right inside them. But in humans, you just cannot do that. So this is absolutely fantastic, and I think will really sharpen the ability to do experimentation and find out what drugs are doing instead of having massive, rather blunt trials. You'll be able to focus this much better. So I've got to get across the stage here because I've got myself out of I'm not to run any more marathons. I have to keep away from vascular surgeons. But thank you very much.
It's very kind of you. Thank you. Thank you.